right. So I'm going to talk about point of care testing. There's several different things that we use and are coming up the pipeline for point of care testing. I'm just going to first tell you I'm focusing really on the TEG and Rotom in this talk, and you are going to get tomorrow from Dr. Botwick a more in depth on a continuous pulse oximetry. So I just, for hemoglobin monitoring. So I'm not going to touch on that so we don't overlap a bit. So that's just a plug for tomorrow morning. You'll get more of some interesting point of care testing. So let's jump into this. So I have just listed the objectives. As I mentioned, we're going to focus on the TEG and the Rotom and actually review some of the literature and kind of see where we're at. In addition, I'm going to talk about platelet analyzer functions and to assess platelet function. So that'll be an additional point of care testing we'll talk about. So first, we have the TEG versus the Rotom. These are two different machines. You can see them there. I showed this slide to my husband, who's not a physician, and he said, "Wow, that looks like an espresso machine. When can we get it?" So, So they do look kind of cute and fun, and I'll try to hopefully delineate the differences between the TEG and the Rotom. So first difference, you can see the different thrombolastograms there. I don't know if this has a pointer. Let's see. I don't know. Does this have a pointer? Okay, sorry, I should have asked about that. Okay, it's not working. All right. Okay, we'll just move along. So the TEG, so you can see up there the thrombolastogram for the TEG. Now, the way the TEG works is the actual cuvette spins, as you can see there, while the blood there it oscillates back and forth with the cup, and the blood just stays in that little cup area. In the Rotom, there's, and you can see in that B picture, that it has a different thrombolastogram. And how that works is actually the pin in the cup is what rotates, and the cup actually stays stationary. And there's some optics that you can see in the diagram that actually give you the thrombolastogram. And the reason for the optics has to do with movement with the TEG, which we'll talk about the benefits of both TEG and Rotom in a moment. So here they are. So when I first did this talk, I was thinking, okay, what's the difference between TEG and Rotom? Other than one's made in the US and one's made in Germany, there has to be differences. So I found an article in a British anesthesia journal that actually did, one of the things that they have is a head-to-head trial where they take some device and they have a group of anesthesiologists learn it and do a head-to-head challenge and tell them what their advantages and disadvantages are. And so what this group found was the TEG is actually less expensive. It is well known. It does have good technical support, so those are the advantages. The disadvantages is you have 2 channels per machine, and we'll kind of talk about the different advantages on the Rotom in a moment, but that there's something to be said about the multi-channels that the Rotom has. You have to do manual pipetting on the TEG, and one of the points is that it's more prone to vibration. And I asked a colleague of mine who was deciding when they were going to purchase it at the VA whether they were going to get TEG or Rotom, and for him, the biggest issue was this vibration. You can lose the thrombolastogram with any movement, and so that's why he had wanted to go with something like the Rotom. So there you can see the advantages is basically it's resistant to vibration. So you can go along and do your thrombolastogram, and if somebody moves the table where it's working, you don't have to start all over again. You do have automatic pipetting, and you have a 4-channel area to pipette. And actually I'm going to show you pictures of these thrombelastograms so you can see the differences in what you get from the TEG versus the Rotom. Thanks. So the disadvantages, it is more complicated, and you guys are going to see in a moment the complication as we review some of the different Rotom diagrams. And the running costs may be increased for the occasional user. And so we'll talk again, at the end, I'm going to share with you some limitations on both of the TEG and the Rotom. So let's touch about the training. I mentioned the training that has to happen. I've actually asked, San Francisco General is one of the places where they use it, and they started the Rotom, I would say probably about a year ago, and in the midst of doing that, they went through lots of intensive training. And I also talked to my colleagues at the VA who haven't yet got the Rotom up and running. But what they did tell me was there's a lot of institution-specific training that has to be done. Each individual has to have extensive training, and you need to have yearly recertifications. You also have to have a dedicated staff that's going to help facilitate the learning and recertifications and the troubleshooting, and start, if a new staff comes on, maintaining their certification. And so what we do with residents is we have the residents can pull the blood, but they don't go through the process of learning how to train on the Thumbbone Lastography. They actually just give it to the faculty member that has already had the training, because it would just be too cumbersome to have our residents coming in and out and training on it. So there's something to keep in mind between both the TEG and Rotom. So I'm just going to go into the specifics of what the TEG and the Rotom do. This is the part in the talk whenever you show a coagulation cascade, much of the people go off and say, I hope they have more coffee. Maybe I'll take a coffee break. So I won't belabor this, but I wanted to just, you need to understand that there's the intrinsic factors that we're both going to be looking at in the TEG and the Rotom, the extrinsic factors, and then we have our common pathway there, okay? So a couple things that we have to go over so that you guys can understand the benefits of the TEG and the Rotom is first a couple definitions. So we'll make it as clear as possible, but the TEG and Rotom have different abbreviations, of course. Makes that a little more complicated. So the clotting time is in seconds, and you can see the abbreviations. We'll start with the TEG first. That is basically assessing the coagulation and the primary clotting factors and the activation, okay, and that's in a time. The K, or the clotting factor time in the Rotom, is the development, the rate of the clot development, okay? So you can think of it as the rate that the clot forms, and then the alpha angle. These will become clear when I show you the pictures. So that's basically the strength and the rate. And for the TEG, you have the maximal amplitude, and that's actually the contribution of the fibrinogen and the platelets to the clot. We won't touch on too much of the amplitude, but that's basically you can set the time, which allows you some flexibility to assess the rate of the clot formation at various time points. So let's touch on the TEG here. So you can see this is a common TEG diagram that you guys have probably seen. The key thing to note that on this side, you have coagulation, and there's all of your factors, the R, the K, the angle, and the maximal amplitude. And then as it continues on, you have the fibrinolysis. Okay? So here's a couple examples of what if you guys have seen the TEGs or read about it when you were way back when we were all studying for our anesthesia boards, you might have seen this. So here's just a common Thumbbone Lastography output. So normal, okay? And so you have your factors. Here's your angle, your maximum amplitude. You have your R here. Okay, and now you can see the difference. Hypercoagulation, you have a decrease in the time for the R and the K, and you have the angle is much more increased, the alpha angle and the maximal amplitude. And then here you can look at platelet dysfunction. So in that, you've got the R and the K, which are normal, and you can see the angle is different, shorter, and the maximal amplitude is decreased. And again, we've got some other ones that you can see here. Now, the interesting thing is if you can see the fibrinolysis here. Again, as we mentioned, this part of the graph is all about the fibrinolysis, okay? So those are your standard thromboelastogram interpretation for the TEG. So we'll move on to the Rotom, and this is where you're going to see the differences in what the TEG and the Rotom do. We went over those factors again: the clotting time, the clotting, the clot formation time, the alpha angle, and the maximal clot firmness. The interesting thing about the Rotom, here's your standard graph, okay? And I'm just going to point out, as we look at some examples, the green, the clotting time, is right here, okay? The clotting formation time is this pink area. and then you have your alpha angle, and then you're going to have your maximum amplitude, and then continuing on the lysis. So the structure is still the same as the tag, it just has a little different formation. So the way it's done is you take a citrated tube of blood, of whole blood, and then you put calcium chloride in it, and that's, it's recalcified, and that initiates the coagulation. And so you can get several different thrombelastographs depending on what you want to look at. So you can get the XTEM, which is going to do the intrinsic pathway, which is why I showed you guys the coagulation cascade, the intrinsic pathway. And the intrinsic pathway is a baseline test that you can then add heparinase, and you can look at heparin reversal. The XTEM basically is a baseline to then get the clot strength from fibrinogen, the component from fibrinogen, and the APTEM, which will tell you the fibrinolysis by adding a protein. Okay. And so at this point, it all looks like we're looking at a Rorschach, and I'm about to tell you, I see platelet deficiency. This angle here looks a little steep. So yes, it feels like that. But I just wanted to give you some examples as we go through. And again, really at this point, you can look at it and just see what you can get out of it. And I'll point out some subtle differences between various clinical deficiencies on the Rotom. So here to start off with, normal patient. Again, we've got the XTEM, which is the extrinsic pathway, the intrinsic pathway, the INTEM, and the FibTEM, which is the fibrin or clot strength, and then the fibrinolysis, which is the APTEM. So for comparison, I've got, this is your normal. On this side is always going to be normal, okay? So this is a patient that you would have that has a platelet deficiency. And so the thing that you can notice is the FibTEM is actually normal, right? So, but you do notice that you've got a difference in the CFT, and you know that the angle is narrower, and so you know there's a clotting deficiency. There's some factor that's a problem, and it's not the fibrinolysis pathway, because you would see something in this. Okay, that's normal. So you can assume then that there may be an issue with platelets. So now let's look at the fibrinogen deficiency. So you can definitely contrast that with the platelet. So here you see now the FibTEM is actually much different than normal. And so that can tell you this patient may need fibrinogen. So now looking at the fibrinolysis part, okay, so you can definitely see a difference here. The angle drops down, thins out, and you see the APTEM here, which the important thing about the APTEM is, as I said, you know that the fibrinolysis is an issue. You see that's different. And then you have the APTEM, which actually you give, in order to do that, if you remember the diagram, you give a protein, and that's an antifibrinolytic that inhibits the breakdown of the fibrin clot, and you're essentially correcting the problem, and so you end up with a normal APTEM. So it's kind of by a way you reverse. By reversing that, you're able to see that this is an issue of hyperfibrinolysis, okay? And now here's where actually a lot of the cardiac groups use Rotom for them, for their practices for the influence of heparin. So the way you do the HepTEM, as I mentioned, the first track is you do the INTEM, and then you add heparinase. So you basically neutralize the effects of the heparin, and you end up seeing that it's now normal. Okay, so if it wasn't, that you know that there's a heparin influence in that portion of it. So again, this is by no means a complete evaluation of the Rotom, but you can now start to see how you can get much more elaborate information from the Rotom as compared to the tag, although it does make it much more complicated. So what does that mean for obstetrics? So I have this diagram here to show you that if you noticed a couple things. One, it's 2011, and it's basically a study that's just looking at normal values between non-pregnant controls and pregnant women. So where we are at right now is we're just figuring out what is the normal values that we should expect in the Rotom whole blood evaluation for pregnant women. before we can even go beyond to say, well, what happens if someone has platelet deficiency? What happens if they're preeclamptic? So right now we're just assessing what is normal in pregnancy and what do we expect to see, what values do we expect in pregnancy. Here, again, now this is taken again from, it's 2012. We're basically looking at, there's 50 women that were pregnant and then non-pregnant. And again, just trying to figure out what are the normal values. So we're moving forward in our role of TEG and Rotom in obstetrics, but we have to first figure out what values are normal in pregnancy. Just of note, a lot of these studies have basically confirmed what we all knew of the hypercoagulable state in pregnancy. So at least we're all on the right track. Okay, so the Cochrane Collaboration, love Cochrane. It always takes a bunch of data and puts it together and says, how effective is the TEG and the Rotom? And, is it something that we should use for massive transfusion? So they took studies. They had 9 different studies, over 700 patients, and in those studies, only 5 were looking at mortality, but they weren't powered to look at mortality. And what they found was the significant outcomes that they found were the secondary outcomes. There were several things that they looked at: ICU stays, they looked at the oxygenation, how long they were in, how long they were ventilated, et cetera, et cetera. But the 2 things that came out were bleeding at 4, 6, and 12-hour time points at follow-up. The Thumbbone Lastography group reduced the volume of bleeding. Okay, so they gave less blood to that group. And then interestingly, the patients that were managed with the Thumbbone Lastography showed a reduction in the amount of FFP and platelets transfused. So in the situations where we have resources with blood and the blood products that are limited, and we are concerned about the risks of transfusion, we could probably do a little better job with the using the Thumbbone Lastography. So I'm going to now switch to the platelet function analyzer, because you might be saying, well, if we have TEG and we have Rotom, maybe we can just use that to look at our platelet function and decide, maybe this is a patient that I shouldn't put an epidural in, or maybe it's okay to put an epidural in. And who are the patients that we're always worried about putting epidurals in? It's the preeclamptic patient. Right? So those are the ones that, well, how bad is their preeclampsia? How low are their platelets? So a group took a look at this PFA 100, a platelet analyzer, using this, comparing it to TEG versus the platelet function analyzer. They did 50 women, and they were measuring just a little bit about the platelet analyzer in comparison to the TEG. They measure closure time. So they basically calculate the time that it takes for a platelet plug to occlude a 150 micrometer aperture in a collagen membrane coated with this platelet activator. So closing time has been shown to be dependent on platelet count, hematocrit, and von Willebrand's factor. So how does this do with our standard TEG and looking at the maximal amplitude? So it was a prospective observational study, and again, they did term preeclamptics, so they were not preterm preeclamptics. They had versus the normal pregnancy patients. Those are the TEG 3000 versus the PFA 100. What they showed was the severe preeclamptic women had increased closure time. They had no difference in their maximal amplitude, so the TEG didn't show any difference. And the platelet counts below 80,000 is when you start to see the influence on the closure time. So just to show you the data here, you can see in the group of all term preeclamptics, the severe ones clearly had a significant difference in their platelet count. And then just to show you here, so the K, which just to remind you, that's the clot formation time. So not really much difference between the controls and the mild preeclamptics, essentially the same, but significant difference when you compare these groups with the severe preeclamptics. And the closure time, again, significantly different between these two groups for the severe preeclamptics. So the platelet analyzer really in this one small study looks like it may be superior to the TEG. And the other thing to note, which I think is interesting in this, is that it's really only for that severe preeclamptic group are they seeing differences. And that's really the group that we see the platelet issues in. So where are we with the TEG and the Rotom and the platelet function analyzers? We need to first really establish a normal value in pregnancy for both the TEG and the Rotom. We need to make sure that there's efficacies for TEG and Rotom in obstetrics, in those patients that we're concerned about for bleeding disorders, patients that were worried about coagulation issues in obstetrics. So we need to evaluate whether this point-of-care testing, the TEG and the Rotom, is actually going to be beneficial over our current transfusion protocols. And the interesting thing is I did a very unscientific, non-randomized controlled survey of my colleagues, and I asked them as they were using in a massive transfusion setting, when they were using the Rotom, because that's what they have, what were their thoughts on that? And many of them said, you know, I could take the blood and send it down to the lab and get a stat test, and that takes about 40 minutes. Or I can do it myself in real time and use the Rotom, and that takes about 10 minutes. But their thought was, well, if I'm, you know, shouldn't I be paying attention to the patient? What's my 10 minutes? You know, so that was one colleague. Another colleague said, you know, it's going to be helpful when I'm doing cases and the surgeon is concerned and wants to give more platelets, but we don't really need it. We're looking at the evaluation of the Rotom, and I don't need to. I have to convince them, look, we don't need it, and so maybe we'll use less products. Having said that, if we're in a massive transfusion, yes, we're probably going to want to be focused on the patient, and we need to have another set of hands probably doing the Rotom or the TEG or whatever, you know, point of care testing that we have. We're going to probably have another set of hands anyway, but that person is going to have to be dedicated to running that data and getting that information. And so the question for people who are in a very busy obstetric ward, the cost and the upkeep and the recertification and all of the issues that go about maintaining these different devices might make sense in a cost-effective analysis, and that, you know, needs to be done. Is this going to work and in what setting? But if it's a rare, small volume hospital where you don't see massive transfusion all that frequently, how is it going to be to maintain that certification for all the people that cover labor and delivery? And are you going to be able to be proficient in it when you really do need it? And so those are the questions that still need to be answered and sorted out. It's an expense to obtain it. It's an expense to maintain it for either one of them. And, you know, the platelet analyzers, some interesting, again, there's still limitations in the time that it takes to get that information. The patient may be delivered by the time you get your, you know, results from your platelet analyzer if you have to send it out. So there may be a role in it, but we still need to look into it and decide, you know, what that role is in specific settings like preeclampsia.